in 10 minutes. Right, so olfactory nerve, obviously. Hello, good evening, and welcome for today's discussion class, PLAB-1. All right, we'll be discussing cranial nerves today, and talk about the 12 cranial nerves. Right, so the first one being olfactory, nerve 2 being optic nerve, nerve 3 being oculomotor. All right, nerve 4 is trochlear, nerve 5 is trigeminal, nerve 6 is abducens, nerve 7 is facial, nerve 8 is glossopharyngeal, nerve 9, right? Sorry, nerve 8 is vestibulocochlear nerve, sorry. Then nerve 9 is glossopharyngeal nerve. Nerve 10 is vagus. Nerve 11 is accessory nerve. Nerve 12 is hypoglossal nerve, right? So, and one thing to note is that you quickly begin to understand that the names of the nerves are related to something about them, right? Before the nerve is named, it has to do with the either the function, the location, the anatomy, all right? That's how it is named. So, for example, olfactory nerve is called olfactory because when you're talking about olfactory senses, talking about sense of smell, right? Optic nerve, you're talking about the eyes, the vision, visual field, visual, right? This is to visualize. Oculomotor is talking about motor aspects of the eye, or aka the eye muscles, all right? What moves, muscles that move the eyes about, all right? Similar trochlear nerve and even abducens nerve, that's nerve 3, 4, and 6, are also involved in the muscles of the eyes, just that there are different muscles that are involved, okay? And nerve 5, trigeminal, all right, trigeminal because it has 3 gemina or 3 branches, 3 major branches. There's V1, V2, V3, right? It's called trigeminal. And they supply the sensory aspects of the face. Okay. Then facial, of course, supplies the motor aspects of the face, and a few other sensories like the anterior two-thirds of the tongue, the inner ear, things like that that make the facial nerve have a little bit of sensory. Then things like vestibulocochlear. It has both the vestibular branch and the cochlear branch, right? And if you know about vestibulocochlear, you realize that cochlear is within the inner ear, also the vestibular, also within the inner ear, and it's involved in maintenance of balance. Okay, so anything that affects the vestibulocochlear nerves will affect balance. Why cochlear attends to hearing, okay, affect balance and hearing. So there will be balance impairment, vertigo, all right, and all those stuff. And there will be hearing impairment as well. Okay, then nerve 9, glossopharyngeal. Glosso, I think when you talk about glosso, you're talking about the tongue essentially. Then you're talking about glossopharyngeal, so tongue and pharynx. Okay, so it talks about the posterior. Remember we mentioned sensory or facial nerve in the anterior two-thirds of the tongue. So we're talking about glossopharyngeal nerve. We're talking about the posterior one-third of the tongue. Then the pharynx, of course, those pharyngeal muscles, and even the sensory aspects of the pharynx, the gag reflex, all those stuff are catered for by the pharyngeal nerve, nerve 9. Then nerve 10 is vagus nerve. Vagus is like chief parasympathetic nerve because it's very long. I don't know, I can't remember why it's called vagus. Right? Vagus. I can't remember why, but there's a reason. I'll find it and tell you later. So it's very, very long. It even involves the heart, involves even the and fibers are carried by vagus nerve. So that's about that. Then accessory nerve, accessory involved in all these accessory muscles of the neck. Okay, that in fact that's the muscle that helps you to total. It caters the sensory one third, posterior one third of the tongue. Sensory sensation of the posterior one of the tongue, all right? But the hypoglossal nerve, all right, is involved in the mood too. You are able to move your tongue because there are muscles embedded within the tongue. So the hypoglossal nerve will, that's general summary of the tongue. Dr. Noya, did you just change to K just now, or basically joined the class and left? All right. So let's see where we can trace the pathway of the olfactory nerve. I know it's from the nose. You have this. Also that COVID-19 affects the olfactory nerve. That's how it causes loss of smell, anosmia. Yeah. So sensations perceived by the body, we don't have to go into everything. So the olfactory nerve is the first of the 12 cranial nerves and one of the few cranial nerves that carries special sensory information only. In this case, the olfactory nerve is responsible for our sense of smell. Okay, so the other information originates in the epithelium of the nasal cavity and is transported to the brain via components of the olfactory nerve, cranial nerve 1, and the olfactory pathway. Okay, so a decreased sense of smell has been associated with Parkinson's disease and thus can be an important clinical marker in this and other states of disease or injury. The thing that we are talking about neurology because Parkinson's disease also causes anosmia. All right, to understand the olfactory nerve and its clinical implications, we have to look at this. By way of function, you know, its special sense of smell. Olfactory cells are olfactory receptor cells, okay, that are found in the nose, all right, the roof of the nose. So the olfactory nerve is formed out of a collection of olfactory receptor cell axons, okay, which pass through the cribriform plate. Thank you. I was looking for this roof of the nose, yeah, the roof of the nasal cavity. Okay, so the olfactory bulb is the relay station of the olfactory pathway and contains olfactory glomeruli. All right, so olfactory tract is made up of axons of mitral relay neurons, then olfactory striae, olfactory cortex, found in the piriform cortex, amygdala. All right. So let's take a quick look. If you look here, you will see that this should be the cribriform plate. Okay, so they are like olfactory receptors here, and you know receptors will have axons, will have cell bodies, axons, and all that. So eventually, all the receptors will carry impulses and connect with branches from the olfactory nerve, which eventually takes the information as it. This is the olfactory bulb, okay, with axons leaving it and penetrating through the cribriform plate. This is the cribriform plate at the roof of the nasal cavity. This is the nose itself, the, um, the epithelium of the nose, okay, which has the olfactory receptors, which perceive the sense of smell. Okay, they pierce this cribriform plate, take it to the olfactory bulb, which now relays the information via the medial olfactory striae, okay, and eventually gets to the olfactory cortex. And the cribriform plate is part of the ethmoidal bone. Makes up the roof of the nose. And the only thing I want to look for is specific place. They mentioned amygdala, but let's look at. So the olfactory cortex, and the information being relayed, the amygdala. Amygdala is somewhere here. Amygdala has to do with and even so kind of part of the primitive brain. So the cortex is not a single structure, rather it's defined as a combined area of several cortex, generally within the temporal lobe. Thank you. So most of the olfactory sense of smell is found within the temporal lobe. So that they receive input directly from the olfactory bulb, and it includes the piriform cortex, which is located below the olfactory spine, amygdala, which is located anterior to the temporal inferior horn of the lateral ventricle, associated with the emotion of fear. Okay, so perceive something and you begin to fear or something. I know, I told you it's a primitive reflex. So there are some things primitive. If you notice, you know that animals, like let's say dogs, have very, very strong sense of smell, just like cats. Okay, so and why they have a very strong sense of smell is because they are lower down in the evolutionary pathway, right? So humans are higher up. So our sense of smell is lesser. And that tells you that information is being taken to the primitive aspects of the brain, which includes the amygdala, piriform cortex, okay, and tohinal cortex, which is the anterior part of the parahippocampal. And also, when you hear hippocampus and parahippocampus and all those gyros, you know that information is actually going to the primitive area. And it's the hippocampus that caters for memory. Okay, so campus, campal gyri involved information of memory. Okay, so there are also some output structures. So from the olfactory cortex, information about smell is sent to the orbitofrontal cortex, where the dorsal medial nucleus of the thalamus. The orbitofrontal cortex portion of the prefrontal cortex that is located in the underside of the frontal lobe and situated over the eye orbit. So what they are basically saying is that visions of this cortical region can result in an inability to distinguish different odors. Now, when you are talking about the issues with smell, there's anosmia, parosmia. Okay, anosmia is the one that has become popularized by COVID-19, where a patient cannot smell, can't even perceive any smell at all, absence of smell, loss of smell. Okay, loss of the ability to smell. That's anosmia. Then parosmia is a situation where you perceive and you perceive smells, but you're not perceiving it as what you're supposed to perceive it as, right? So let me look at. So they all fall within dysosmia. So dysosmia can fall under different categories. A distortion of the quality of the perception of an odor, known as parochia. Carcosmia is when you begin to perceive things that, all right, like the carcus, so carcosmia. Then parosmia is just that distorted ability of the ability to perceive smell, all right, in the same quality as what you are perceiving, all right. So you perceive something as another thing. So then phantosmia, where there's perception of an odor when no odor is actually present. So this is what is also known as phantosmia or olfactory hallucination. So these are all problems with smell. So when you see a patient with anosmia, there are so many things that can cause it, at least neurologically. We have some neurological degenerative diseases like Alzheimer's disease can cause anosmia. Mentioned Parkinson's earlier. Okay. Schizophrenia, of course, can have anosmia or they can have parosmia, they can have carcosmia. Okay. Then diabetes itself can also cause Parkinson's chorea, Parkinson's disease, multiple sclerosis, right? Pick's disease, which is a form of dementia. So a lot of different types of dementia, dementia itself, Alzheimer's dementia, Pick's disease, Huntington's chorea. Okay, then the related stuff like Parkinson's disease can also cause anosmia. So congenital can also be congenital anosmia. Diabetes mellitus, something very common like diabetes cause anosmia. Then there are also others that um, arise due to brain injury. So brain tumors or aneurysms that press on a part of the olfactory pathway. Head trauma with a fracture of the superior orbit or anterior cranial fossa. Yes, thank you. So anything that fractures that cranial plate, all right, is likely to destroy a lot of the axons that take the information from the olfactory receptors to the olfactory bulb, right? So I think that's logical. So on that note, call it a night. So olfactory testing, when you want to test, usually you should use something that has strong smell, like peppermint, right? So menthol, coffee, peppermint, okay? So that once the person perceives it, the person perceives it. And usually, I think you close one of the nostrils, tell the person perceive on one side, then close the other. And once you know if there is an anosmia, if there's anything, whether it's unilateral or bilateral, that's a very simple test for cranial nerve 1. Okay, so we'll continue with the other cranial nerves in subsequent lectures.